Welcome to Doctors on Call. I'm Jenna Miller. Chronic wounds are a significant burden to the global healthcare systems. With the increase in the aging population, the prevalence and complexity of wounds are only expected to increase. Likely candidates for treatment are those suffering from diabetic ulcers, pressure ulcers, infection, and wounds that haven't healed within 30 days. How are these wounds treated, and how do you take care of a wound after surgery? We'll tackle these issues and much more tonight on Doctors on Call with our guest, family physician, Dr. Tyrel Somers.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Russell Regional Hospital, experts, neighbors, friends.
Prospectively Healthy and Wellness Clinic, where health and wellness begins. Naturopathic medicine, IV therapy, and wellness services.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.
Dr. Tyrel Somers received his medical degree from the University of Kansas School of Medicine in Kansas City. He completed his residency at the University of North Dakota Center for Family Medicine in Bismarck, North Dakota. Dr. Somers is board certified through the American Board of Family Medicine and is a member of the Kansas Academy of Family Physicians, American Academy of Family Physicians, and the American Medical Association. His professional interests include chronic wounds, gastroenterology, psychiatric care, diabetes care, and joint pain. He has been affiliated with Russell Regional Hospital since 2015. Dr. Somers is married with 8 daughters and lives on a small farm south of Russell where he enjoys caring for his many animals. I hear chickens were today. Our phone lines are open at 800-337-4788 toll-free if you have any questions regarding wound care on today's show. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you so much for joining us and taking a break from the farm work to come join us tonight. First of all, let's talk about what are the most common wounds that you treat at the hospital.
So there are a bunch of different types of wounds, but there are 4 primary subcategories of wounds that we treat. The first category would be pressure ulcers, so things that are caused because of excess pressure on a specific area of the body. Diabetic foot ulcerations, they happen because of diabetes and neuropathy that's associated with diabetes. Arterial ulcers, which are caused by peripheral vascular disease. And then finally, venous stasis ulcers. And again, they're all pretty equally prevalent. As I say, one is more common than the other. It's not really true. It just depends kind of upon what's happening and what's going on, whether you see one more than the other.
Sure. Now let's talk a little bit more then about, let's start with pressure ulcers and how those affect a patient.
Yeah, so pressure ulceration happens in a patient when there's a spot in the body that rubs excessively against a very specific pressure point. Common places include heels, coccyx, which is the tailbone, the hips can sometimes get it, and any place where you can have excessive pressure is there. What happens is over time, the sheer mechanical force of rubbing and friction against the skin wears down the underneath skin layer. That then can cause damage to the underlying dermis, which is the layer underneath the skin. That then can cause problems with infection coming in, that can cause problems with compromised blood supply coming in, and can lead to a whole host of problems. Most of the time, people are at risk for pressure ulcerations when they suffer from some underlying condition that weakens their body's effect on kind of the sensation that they have in the area. So if a person has an underlying neuropathy, which is a nerve-based condition, if they have a problem with like a paraplegia from a nerve injury, or if they're prolonged hospitalization where they were sedated because of medications or like on a ventilator, or for any number of reasons that just makes it so that they don't feel the pressure on your skin. Normally when you're sitting in position, you can even see Dr. Somers. I sit here and I kind of move myself back and forth and kind of shift the balance off of my hips. That's a normal response that everyone has to help prevent pressure ulcers. But you can imagine if a patient's sedated and not turned by staff as they should be, they can be at more risk for forming these ulcerations, which can be tricky to manage and tricky to heal from.
Okay, so let's say the pressure ulcer comes. What next?
So the next best important thing in the pressure ulcer is finding a way to offload that ulcer as much as possible. With all wound care, honestly, the biggest thing is finding the underlying cause and why the wound has occurred and then trying to correct that as best as you can. And with pressure ulcerations, that typically means we have to offload them as much as possible. With heels, it's very easy because you can put them in specialized pads, specialized kind of boots that they can wear to help offload, or you can even kind of offload off of a pillow if you need to on the backside of the calf. There's a whole bunch of different things. When it comes to the tailbone area, it's a little bit trickier because a person has to always sit or lay down and put pressure onto that. So we often have to give special instructions to nursing staff and caretakers to help off-shift as much as possible the pressure off of that backside to help reduce that. The next thing you want to do is you want to start looking at ways to help speed up the recovery. There's a bunch of different techniques that we use in wound care to help do that. The most important thing is a process called debridement, which is a selective kind of treatment where a physician goes in with either a curette or with a scalpel or with some type of underlying mechanical device to help remove layers of the underlying tissue that are exposed to air or that are exposed to bacteria to get to a clean kind of base of the ulcer itself. When that happens, you can allow a lot quicker healing and a lot quicker recovery time by using the body's own kind of immune system and the body's own healing process to your advantage.
Absolutely. Now, can a pressure ulcer get so bad that it won't fully heal?
Yeah, pressure ulcers are really notorious for being very tricky to heal, especially the ones that are on the tailbone area. They're very, very hard to get there. If they don't heal via conservative methods. So let's say we offloaded the patient and Dr. Somers did a little bit of debridement and tried his best to clean up what he could, and using specialized dressings we still couldn't heal it. There are some other options that are available for pressure ulcers, especially ones that are a little bit deeper. Wound vacs are a very common thing that are employed kind of first line after that happens, in which you use a piece of specialized foam that goes into the actual wound itself, and then we use a vacuum. It's a very small medical device that then pulls a specific amount of pressure to help pull in that underlying tissue and allow new epidermis, new skin layer to kind of fill in over it. Vacuums are very, very effective. They work very well to help with those, but they're not 100% foolproof. Some individuals have to go through further kind of evaluation. Some even have to go through a process that's called a wound flap, which is basically where you take a section of good skin from another area, move it over and around the area of the pressure ulcer to help cover kind of both of them. And that's something that's performed by a very specialized surgeon, like a plastic surgeon or a generalized surgeon who's trained in wound care.
Sure. You mentioned the diabetic foot ulcers. Let's talk about those.
Yeah, so diabetic foot ulcers are their own unique thing because it's a similar form to a pressure ulcerization in that they're typically caused by shear, by stress, but in diabetic foot ulcers, they are accompanied by type 2 diabetes and type 1 diabetes too. Anyone that has an excess in sugar levels can cause a form of neuropathy in which the nerves are basically coated, for lack of a better term, with the sugar so that they don't have the same sensation, the same feel as they would normally. And because of that, it makes it so that that person can't shift and offload as well. On top of that, diabetics have a very unique form of neuropathy where their skin surface, especially on their feet, becomes more dry. And because of that dryness, it makes it more prone to tears, to shear as well. And then finally, on top of that, diabetics, because of these kind of problems, they don't walk on their feet normally like normal individuals do, and that causes changes in the underlying foot architecture. So the actual like bones themselves, as well as like the arch of the foot, tends to be more flattened, tends to be more rounded, so that ulcerations are much more likely to occur. This is why diabetic foot ulcers are so challenging compared to other pressure ulcers, because you're dealing with many different complex things to help heal them. You're taking care of type 2 diabetes or type 1 diabetes with proper sugar management. You're taking care of offloading as much as you can, but also too, you're trying to fix an underlying architectural problem that you need to shift off weight. And that typically means you have to get specialized orthotics, like very special inserts that go into shoes, or specialized shoes even, that help offload that kind of roundness, that flatness that I spoke about earlier.
Sure. And then you also mentioned the ulterior ulcers.
Yeah, so arterial ulcers are caused by peripheral vascular disease. Peripheral vascular disease is a process in which blood flow is compromised going down to the legs. It can happen in other areas too, but it's most commonly there. I often equate it to my patients as very similar to like a heart attack. So over time, plaques, calcifications, all sorts of things can lead towards slowing down a blood supply down to the lower extremities. When that happens and blood flow is compromised, you can't get good nutrition, you can't get nutrients to the skin and the underlying tissue. And when that occurs, it becomes infected, necrotic, and it can actually form ulcerations because of it. The hallmark kind of treatment for peripheral vascular disease and arterial ulcerations is trying to restore blood supply to that specific area. We have very specialized surgeons called vascular surgeons that will often refer patients to, that they can go in and they can revascularize the area towards the arterial ulceration. They can do that with angioplasty, which is where they put a small little stent in and then balloon it out and open it up, or they'll actually put a permanent stent in, and that's the much more common thing. Well, they'll actually put like a small piece of wire mesh that opens up the artery and keeps it open so that blood flow can flow through. Once that happens, honestly, arterial ulcers heal very quickly if there's no other underlying comorbidity that happens. One of the interesting things about wound care that comes along with not just peripheral vascular disease, but also to all of the types of wounds that we manage is there's a lot of underlying comorbidities and problems that a patient will present with that delay wound healing as well. And so managing along with a good primary care doctor is crucial to help make sure that they're receiving the type of care that will help benefit their wound healing.
Sure. And at what point does a wound become chronic?
So a wound becomes chronic once it's been present for more than 28 days or 30 days. It depends upon who you kind of believe in regards to that. Regardless, if it's been there for more than a few weeks, it's probably a wound that needs to be checked out by at least a primary care physician so that they can check and see if there's anything they can do to intervene. If they look at the wound and they believe it would benefit from being seen by a wound care specialist, it's also really important to get them to a wound care specialist so that that selective debridement that I spoke about and also dressing management and other things can be taken into account to help heal the individual.
Sure. And what are some of the causes of delayed wound healing?
So the primary cause that happens that makes wounds not heal is a kind of recurrent pathway that happens in the inflammatory cascade of the body. Our bodies naturally want to heal wounds. When we have a hole that's there, the immune system brings in certain cells, white blood cells, certain types of accessory cells, platelets, things like that, to help us stop bleeding from that wound, to bring in the right things to clean up that wound, and then use specialized cells to help pull it together, and then the skin cells will grow over that. What happens in a chronic wound, though, is somewhere in that pathway, something stops it from occurring. And so you end up in this chronic state of inflammation that just keeps going over and over and over again and makes it harder to heal the wound. In fact, when we undergo debridement and do our specialized treatments that we give in wound care, we're trying to reactivate the acute inflammatory phase to stop that chronic inflammatory phase to hopefully allow the body to help heal or help heal the tissue rather than like allowing your body to just continue having that wound there present.
Sure. And when a patient comes in, how do you make an assessment of the wound?
So when a patient comes in to assess a wound, there's a couple different things that we do. The very first thing we do is we'll clean the wound off. We get measurements specifically of how big the wound is, both width, length, and then depth. The next thing that we'll do is we'll start doing an assessment of the skin around and then the blood flow going to that area. We'll also feel for pulses. Sometimes we'll use a Doppler device, which is a very specific ultrasound-based device that helps us determine the amount that's there. We'll look for swelling around the wound and measure the distance and diameter around the caps to see if there's something going on from a swelling standpoint that we can benefit from. The main thing that we do, though, is we try to identify what source is causing that underlying wound so that we can target how to correct that underlying source.
Sure. And you mentioned cleaning. Why is wound cleaning such an important step?
Yeah, so wound cleaning is an extremely important initial step because we're trying to get the area underneath that wound to be as clean and as healthy as possible. Often there's some, I don't really want to say contaminants, but there's some debris that can be found within wounds that can be healthy debris in acute wounds, but in a chronic wound, they tend to inhibit the actual growth underneath it. There's what we call wound slough, which is basically just cellular byproduct that's left there from good cells and bad cells and can sometimes harbor bacteria. So cleaning off that wound is really important. The hard part is we've been trained as our younger ages to use specific types of things to heal and kind of clean wounds that may not be as good for wounds as we thought they were. One great example is hydrogen peroxide. Everyone loves putting hydrogen peroxide on a wound because it fizzles, it bubbles, it looks really cool, and you believe that because of that it's healing the wound. Truth be told is initially, when you first have a wound, that is really good because it gets rid of the bacteria. But the problem is further along as you use the hydrogen peroxide, it doesn't just kill the slough and other things in the wound, it also kills off good cells and things that you want to be there. And so hydrogen peroxide can actually delay the healing of a wound, especially in the chronic state. So it's one of the things sometimes we have to counsel patients on. You have to be careful with hydrogen peroxide because it can definitely cause problems with the wound healing process.
Sure. So if a person has a wound, depending on how deep it is, you can use hydrogen peroxide at first, but then maybe that's it?
Absolutely. Yeah,
Okay.
hydrogen peroxide is a good initial cleaner, but much past that, it doesn't have as much benefit.
Okay, very interesting. Now, is it better to cover a wound or leave it open?
Depends upon the size of the wound and the type of the wound. Most of the time in the initial stages when you have a wound, it's much better to start by covering the wound with some type of bandage or dressing, to be truthful with you. And that's primarily to help manage not only reducing bacteria coming into the wound, but also will help manage the type of discharge and things that can come out of a wound. Oftentimes when a wound kind of is initially there, some of the cellular byproducts that are brought in by the inflammatory response are good things. And you can see that as kind of a yellow or even like a yellow-brown kind of discharge that comes from the wound. Those things are okay. Those things are safe. Things that you want to avoid or things you want to watch out for specifically are wounds that have like purulent discharge, which I mean like pussy, kind of thick, wider kind of discharge, which is not as good within a wound. That can be a sign that there's an underlying infection, can be a concern on what to do next with the wound.
You had mentioned the dressings. How often should those be changed?
So dressing management is very, very tricky when it comes to wound care because every single dressing that we use as a wound care specialist is different and unique. Some have to be changed every single day. Some can be left on for upwards of a week or even 2 weeks sometimes. So it really just depends upon the type of wound, the wound dressing that's used, and other things. In a normal wound, like an acute wound that you get from a laceration, cut, something like that, most of the time changing that dressing daily or every other day is more than appropriate for that. So let's say that you're at home, you cut yourself, you put a Band-Aid on it, you can leave that on place for up to 24 hours and then replace it after that.
Sure. And how do you select the appropriate wound dressing?
So by far the most important dressing initially is just getting something that will be absorptive, that'll help pull away those discharge that I kind of mentioned earlier. Any kind of non-adherent dressing is completely appropriate and okay. You just want to make sure that it can cover the entire circumference, the entire diameter of the wound. So choosing the right size is probably the more important thing than the right dressing selection. But any of the adhesive bandages that are available over the counter are probably fine for most individuals that are there. There are some that are medicated versus non-medicated, and it's hard to say fully which one is better. I have some people that swear up and down by using medicated ones, or at least putting like a topical triple antibiotic over the wound. If a wound was grossly contaminated, that does make sense after it's been cleaned out. But for most wounds that are pretty clean and pretty non-risk for infection, they're probably safe to just use a regular adhesive bandage, truthfully.
Sure. And is it true that the ointment can prolong the healing at times?
Yeah, and that's the big problem with using an ointment. It's kind of similar to hydrogen peroxide in that our body does have good natural defenses to handle this, and sometimes using a triple antibiotic ointment or similar ointment can be bad within a wound to heal it. Sometimes as a wound healing professional, like I use very specific dressing changes and ointments to help with it, but that's in use specifically for people who have risks with chronic infections. For most people, you want to use just a single ointment the very first time you have it in a contaminated wound that's been washed out and irrigated thoroughly, and then after that, it's probably just safe to use a regular adhesive bandage. You don't necessarily need to use a medicated bandage or an ointment.
Sure. And we talked maybe a little bit about this earlier, but what are some of the signs and symptoms that a wound is actually infected?
So I mentioned earlier the presence of purulent discharge, which is a very specific type of discharge that's much thicker, kind of white, maybe grayish in its discoloration. Wounds also become a lot more tender, a lot more sensitive when they're infected, at least compared to when they were when they initially happened. Another thing is redness, especially very, very dense redness. It's not uncommon in the very initial stages of a wound when inflammation is happening actively for the first day or two for there to be some redness around the wound. That's completely normal. But that redness begins to spread. If it becomes more hot, if it becomes more aggressive, that can be a sign that there's an infection there. Normally, a wound does improve with its pain after a few days or so. If that pain continues to persist, that can be a sign that it's infected as well.
Sure. And at what point does a person need to go see their doctor?
By far the biggest thing to see a physician for is if you think that it's infected, that's an important aspect to do. Another thing to see is that length of time that we kind of mentioned. If you have underlying risk factors, going to see a physician sooner would be worthwhile, especially in diabetic patients that have foot wounds. They're definitely much more apt to need to go see a provider sooner. For most of my diabetic patients, I tell them, if it's been a week and a half that you've had a wound, it's probably best to come in and have us take a look at it, even if it hasn't met the definition yet of a chronic wound. But other than that, most of the time, if it's something that you're worried, you're concerned about, always going in and seeing a provider is worthwhile.
And how often do you have to prescribe an antibiotic for the healing process?
So for most patients, we actually don't have to prescribe an antibiotic for a wound unless it becomes more chronic. I'll be truthful, once a wound does hit about that 4-week mark, it's not uncommon that we're culturing the wound, or at least obtaining tissue samples from the wound and sending it off for culture. And then based upon that, we'll treat with antibiotics at that point. But when I normally see a patient for wound care specifically, I don't really start them off with an antibiotic unless it's showing signs of an infection, or if I have a culture that tells me I need to treat it with. So it's not a super common thing that you need to have an antibiotic for a wound, but if it's contaminated or you have risk factors, it's not a bad thing for a physician or a provider to give you one.
And that was actually my next question, was the tissue biopsies and if they're needed if a wound fails to heal.
Yeah, so tissue biopsy can be an important aspect of trying to figure out if a wound is having problems or not. We probably do tissue biopsies, I would say, in about 1 in every 10 wounds that I see personally, but it does happen a lot more frequently than people think. Sometimes there are some very unique and very abnormal wounds that aren't the normal 4 that I mentioned earlier. If we have suspicion that that might be the case, we will get a tissue biopsy as well for those wounds. I would say most of the time a tissue biopsy should be done, though, by a wound specialist and should be done under the management of a very specific pathologist, because when we're looking for those specialized types of wounds, there's certain things, certain stains, certain ways we want those individuals to be looking at those wounds. And again, another great reason to send someone to a wound care specialist.
And we talked earlier about the ointment and the hydrogen peroxide sometimes inhibiting the healing process. Is there a way to speed up the wound healing?
So there is a way that you can help kind of improve your wound healing. One of the biggest things is nutritional. Nutrition plays a massive role just in your general health, and I think we hit this almost every time that I come in and see and talk with you guys. Nutrition is extremely important. And in wounds, one of the key factors is protein and protein intake. Skin and the underlying dermis that's there is really reliant upon protein intake. And if you have good protein sources and good protein, that will help you heal faster. One of the things that we do with most patients that we see in our wound care is get some labs, and one of the things we check is the protein level specifically, so we can counsel and coach people to increase that. Studies have also shown that zinc sometimes supplementally is important. However, zinc, if you just take it, can be dangerous, and so often I counsel my patients that unless you've heard from a provider or someone specifically that you should be taking zinc and how much you should be taking, it's one of the things you just don't want to start on your own. But it is one thing that we give for patients sometimes as well.
Sure. And what do you find is the hardest wound to heal?
For me personally, the unique wounds are probably the hardest ones to heal, the ones that I didn't mention as the 4. There's one that I've seen in my practice that was called pyoderma gangrenosum. It's a very specific type of wound that happens when the immune system itself is actually reversing what's going on. And so if you go in and do routine wound care, like go in with selective debridement and try to clean it up and then put dressings on it, it actually makes the wound itself worse. You have to give the person a very specific type of antibiologic treatment that helps stop the immune system's response to it, and that's typically what heals out the wound. That's one of the ones that we mentioned earlier that you have to get a very specific tissue biopsy for and tell the individual you're looking for that specific disease, or else it may be missed even on regular routine tissue biopsy. But it was a very, very hard wound to heal. In fact, I had to take care of it myself. I had a rheumatologist helping me, and I also had a dermatologist helping me on that wound, so it was pretty complex.
Very interesting. Now, if a patient has surgery, when can they take that bandage off?
Typically, most bandages are meant to be left in place for anywhere between about 48 hours to 72 hours, but the surgeon specifically will tell you how long they want those dressings to happen. A lot of the orthopedic doctors use a very specific type of membrane and specific type of dressing that's meant to be on there a lot longer. In fact, some of them can even leave them on until they follow up with the provider a week and a half later. And so the biggest thing is make sure you're looking at those discharge instructions. Make sure you're asking your nurses at discharge, how long can I leave this in place? But a good rule of thumb, if you didn't hear from anyone, is 48 hours, or please, please, please contact that provider to make sure.
Absolutely. We have just a few seconds left. How do you know that the wound is healed?
One of the big things we look for wound healing is to see, A, that the skin is closed around it and that the tensile strength of the tissue is back. So it's a really important thing that if you have a follow-up with a wound care specialist, you go see them because that's some of the things that they'll check out and make sure of.
Absolutely. Well, our thanks goes out to Dr. Somers once again from Russell Regional Hospital for being our guest tonight. On our next Doctors on Call, we'll be discussing pediatrics with Marley Palmer of Pawnee Valley Community Hospital. You can email questions for our next program. That address is doctors@shptv.org. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Russell Regional Hospital. Experts, neighbors, friends.
Prospectively Healthy and Wellness Clinic, where health and wellness begins. Naturopathic medicine, IV therapy, and wellness services.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.